Hello, everyone, and welcome to our first module on cardiac ischemia. So cardiac ischemia occurs whenever there's insufficient oxygen delivery to the muscle in the heart. And generally, this occurs whenever the demand for oxygen by the muscle fibers in the heart exceeds the supply. And usually, this is in the setting of coronary atherosclerosis. So in another video, I talk in detail about the process of atherosclerosis and how plaques form in blood vessels. But when plaques form in the blood vessels of the coronary arteries, you move from a situation where you have normal blood flow, like what's depicted here, to a plaque being present, and that obstructs blood flow and limits the amount of red blood cells and oxygen that can be delivered to the heart. And when this happens, whenever there's ischemia in the myocardium of the heart, it leads to typical symptoms that include chest pain, which is called angina when the chest pain is caused by ischemia. You can also get other symptoms like dyspnea and diaphoresis. And there's a whole range of symptoms that can occur, but these ones here are really the classic ones: chest pain, shortness of breath, sweatiness. This is cardiac ischemia. So now that we understand that angina refers to chest pain caused by cardiac ischemia, let's talk about what stable angina means. So if we look at this cartoon on the slide here, at the top we've shown what should be present in a coronary artery, which is unobstructed normal blood flow. At the bottom, I've shown a stable atherosclerotic plaque, and by stable, I mean the plaque's not ulcerated, there's no thrombus on top of the plaque. And when this happens, symptoms of angina can develop with exertion. We call this exertional angina. So when you exert yourself, like when you walk up a flight of stairs, your heart demands more oxygen. If your blood vessels look like this, that's no problem. The blood flow can increase to meet the demand. But if you have a plaque like this, then the blood flow can't increase to meet the demand, and that leads to exertional angina. And these symptoms are usually stable, meaning they occur with exertion but go away with rest. And that's the definition of stable angina: angina that occurs only on exertion and goes away with rest. And you should be aware that for this to happen, 75% of the lumen at least has to be occluded by the plaque. Many of us have 20, 30, 40%, even 50% plaques in our vessels, but that won't cause any symptoms. The obstruction has to reach about 75% before it will produce symptoms of stable angina. In contrast to stable angina, acute coronary syndromes are what happens when a plaque ruptures and a blood clot forms on top of that rupture. This is depicted here in this picture. We've got a yellow lipid-laden plaque. It's ruptured, and now there's a blood clot on top of it. And what this means is a plaque that may be obstructing only 20 or 30 or 50% of a vessel lumen can suddenly obstruct nearly all of it because it ulcerates and forms a thrombus that occludes much more flow than the plaque does itself. If the occlusion caused by the thrombus is subtotal, meaning it's greater than that 75% threshold we talked about to produce symptoms, but it's less than 100%, meaning it's still allowing some blood flow, then you get the situation we have here at the top of the screen of a subtotal occlusion. You can see some red blood cells are able to get beyond the occlusion. And this is what leads to the two acute coronary syndromes called unstable angina and non-ST elevation myocardial infarction. I talk about these in detail in other videos, and we'll talk about them a little bit in this video, but these are the clinical syndromes that occur when you have a subtotal occlusion. In contrast, if you have a total occlusion, you get what's depicted at the bottom of the screen here. There's a plaque, it's ulcerated, and the blood clot is completely occluding flow, so no oxygen can get beyond the occlusion. This is what leads to the clinical syndrome of ST elevation myocardial infarction, also called STEMI. So unstable angina, non-ST elevation myocardial infarction, and STEMI are the three acute coronary syndromes, and they're all associated with plaque rupture and thrombus formation. The reason that cardiac ischemia is bad, besides the fact that it can cause symptoms like chest pain and other things, is because it can lead to sudden death. This is a common complication of coronary ischemia of any cause. So when patients have ischemia, whether it's stable ischemia that only occurs with exertion or an acute coronary syndrome from plaque rupture, any of these forms of ischemia can lead to arrhythmias, including life-threatening arrhythmias like ventricular tachycardia that can lead to cardiac arrest. And so for this reason, coronary artery disease leading to ischemia is the most common cause of sudden death among adults. In younger patients, coronary disease is uncommon, so the most common cause of death in that scenario is hypertrophic cardiomyopathy, which I talk about in another video. But for all comers, for adults, the most common cause of sudden death is coronary artery disease. So the biggest risk factor for developing coronary disease is prior coronary disease. So someone who's had one myocardial infarction is at much higher risk to have another than someone who's never had a myocardial infarction in the first place. And there are three conditions which we call coronary risk equivalents. That's because The risk of having coronary disease in these groups of patients is just as high as patients who have prior established coronary disease. So these three conditions are diabetes, peripheral artery disease, and chronic kidney disease. Patients with any of these conditions are at such high risk of coronary disease, they're considered to have the same risk of someone who has already had a coronary event. Besides the things shown on the last slide, some other important risk factors for coronary disease are shown here. So two big ones are hypertension, hyperlipidemia. These are called silent killers because they're asymptomatic, but if we identify them and treat them, we can prevent coronary disease. Family history is an important risk factor. In terms of coronary disease, family history means a first-degree relative who was a male who developed coronary disease before age 50 or a female before age 60. Smoking is also a major risk factor, and then so is obesity and a sedentary lifestyle, meaning lack of exercise. So now let's talk a little bit about the extent of ischemia, meaning how much of the myocardium develops ischemia in certain clinical scenarios. So I'm going to draw a little circle here, and this is going to represent the left ventricular cavity. And the dark line here represents the innermost layer of cells lining the cavity. That's called the endocardium. Beyond that layer, we have a thick layer of muscle called the myocardium, and then out here we have the epicardium. And the epicardium is where the coronary vessels sit. So this innermost layer of cells, the endocardium, almost never gets ischemic because it can pick up oxygen directly from the blood in the left ventricular cavity. But just beyond the endocardium, this layer here, which is called the subendocardium, that is the most vulnerable to ischemia. That's because it's the furthest away from the epicardial coronary vessels. In other words, all these cells up here are closer to the coronary vessels. They can more easily pick up oxygen, but you really need proper, normal, good oxygen delivery for oxygen to reach all the way down here to the subendocardium. So if you have a little bit of ischemia, a mild degree of decreased oxygen delivery, you could get what's depicted in the top picture here, subendocardial ischemia. This area in purple has become ischemic. It's not the whole wall of the left ventricle here, it's just the subendocardial layer. On the other hand, if you have more severe ischemia, then the entire wall will become ischemic. Everything will turn purple here, and we call this transmural ischemia. So if you understand that, then you can understand what I'm about to tell you now, which is that transmural ischemia requires more ischemia, and therefore it usually occurs when there's complete 100% flow obstruction, meaning a STEMI. On the other hand, subendocardial ischemia develops when there are milder degrees of ischemia. So this usually occurs when there's flow obstruction, but some distal blood flow, meaning some oxygen is getting through so that only the subendocardial layer is becoming ischemic. And this is what happens in stable angina, unstable angina, and NSTEMI. These are all situations where you usually see subendocardial ischemia. So just to make this very clear, in subendocardial ischemia, usually you have a subtotal occlusion where there is some distal blood flow, but it's limited by the occlusion. This is what leads to subendocardial ischemia, meaning only the purple area here, the subendocardium, that layer of myocardium is what becomes ischemic, not the entire wall. In contrast, in transmural ischemia, you have a complete occlusion, there's no distal blood flow present, and that's what usually leads to transmural ischemia, where the entire wall becomes ischemic, not just the subendocardium. The reason it's important to understand the difference between subendocardial and transmural ischemia is because there are different EKG changes associated with the two types of ischemia. So let's start by talking about ST depressions, which are a finding on EKG associated with subendocardial ischemia. If you look at this EKG tracing on the screen here, this is the PR interval here, this is the QRS complex, and then the ST segment is right here, and you can see that it's below the PR segment. We call that ST depression, and that's a finding associated with subendocardial ischemia. The T wave is also upside down here. We call that an inverted T wave. That's another finding of subendocardial ischemia that I'll talk about in a minute. And if you want to understand the reason why ST depressions occur when there's subendocardial ischemia, let's look at this little cartoon on the screen here. So this is meant to be a depiction of the heart. This is the left ventricle right here, and this is the right ventricle right here. And this is myocardium surrounding the ventricle, and this little blue section here is a small area of subendocardial ischemia. So in this drawing, the entire myocardium is at rest. That's why it's white. But when you have a little area of subendocardial ischemia, like this blue area here, it will send out electrical depolarizations all the time in all directions. So even though there should be no electrical activity, in other words, the myocardium should be at rest, there's actually some electrical activity emanating from this area of subendocardial ischemia. So if this is an EKG lead looking at the left ventricle, it's going to see electrical activity coming towards it, even though the myocardium should be at rest, and that's because of the subendocardial ischemia. So what that does when you have electrical activity going toward an EKG lead at rest is it moves the baseline upward. In other words, it makes the baseline of the EKG tracing elevated like this blue line right here. What happens next is the entire ventricle depolarizes like this. That brings the electrical activity back down to the baseline where it should be. And then once again, you go back to the resting state, but this area of subendocardial ischemia remains ischemic, generating some electrical activity. So the result of all these changes is that you get what's shown right here. It appears to be ST depressions, meaning the ST segment is depressed below the PR segment. But what it really is that the baseline is elevated above normal, and that gives the appearance of the ST depression. Now, everything I've shown you here is relatively low yield. It's unlikely you'll be asked about this on step one. If you find it confusing, don't worry about it too much. But I wanted to explain this to you so you understand where the ST changes come from in subendocardial ischemia. The other major finding of subendocardial ischemia is T-wave inversions, which I mentioned on the last slide. This is an upside down or inverted T-wave. It often occurs together with ST depressions when there's subendocardial ischemia. And so you can see this in coronary artery disease and subendocardial ischemia, but you should be aware that there are many other causes of T-wave inversions besides ischemia. For example, when there's raised intracranial pressure in the brain, that can send electrical signals to the heart via nerve fibers, causing T-wave inversions. These are called cerebral T-waves. You can also see T-wave inversions in resolving pericarditis, which I talk about in another video. T-wave inversions are also a normal finding in patients with bundle branch blocks and left ventricular hypertrophy. So although they do occur in subendocardial ischemia, they're not specific because they also occur in many other conditions. Now let's talk about another EKG change that occurs in the setting of ischemia. This is ST elevations. So ST elevations are seen only with transmural ischemia. This is a picture of what it looks like on the screen here. This is the baseline here. This is the ST segment. You can see that it's elevated above the baseline. That's called an ST segment elevation. And if you want to understand why these changes occur on the EKG, let's look at this cartoon right here. So now what we've got is an area of transmural ischemia right here in blue. Remember, this is the left ventricle, this is the right ventricle. So this whole wall of the left ventricle is ischemic. That's going to send out little electrical signals at rest in all directions like this, just like we talked about before with subendocardial ischemia. So even though the left ventricle is supposed to be at rest with no electrical activity, there is some electrical activity caused by the ischemic area. But because these electrical waves are going away from the EKG lead this time and not towards it, what they do is they move the baseline downward below normal, and so you get something like this blue line right here. Then the entire myocardium depolarizes like here. That causes an ST segment that's above the PR segment. In other words, that's elevated, but it's actually at the normal baseline because we started below the baseline. And then we go back to the resting state, and the net result is something that looks like this. The ST segments appear to be elevated above normal, but in reality, what's causing them is the fact that the ischemia area here, the transmural ischemia, is causing the baseline to be pushed down below normal. So once again, this stuff in here is relatively low yield. I just want you to know why the changes happen. The more important thing to know is that ST elevations are seen in transmural ischemia. And just to make this very clear, here's another example of ST elevations. So this is the PR segment here. This defines the baseline. This is the start of the T wave and the ST segment up here. And you can see that it's elevated above the baseline. And so like I said, ST elevations are the defining feature of an ST elevation myocardial infarction or a STEMI. This occurs when there's significant ischemia enough to cause transmural ischemia. And so what happens is acutely you go from normal on the EKG to what is shown here in the acute setting. After several hours or sometimes even a day or so has gone by, a Q wave will appear. This is a Q wave right here. And then as a couple days go by, eventually the T wave will invert like this. And then eventually the T wave will go back to normal, but the Q wave will always be left behind. So in patients who have an area of transmural ischemia and a transmural myocardial infarction with ST elevations, eventually the ST elevations will go away and the T waves will go back to normal, but they'll always have persistent Q waves indicating that there's scar tissue from prior transmural ischemia. Let's talk about some other ischemic EKG changes you can see that are less common. And first, let's talk about hyperacute T waves. So hyperacute T waves look like what's shown on the slide here. They're basically tall peak T waves. They're very similar and almost impossible to distinguish from the peak T waves you see in patients who have hyperkalemia. But these can also occur when patients have ischemia, but they're only seen in transmural ischemia, and they're a very early sign. They tend to come on before ST elevations. So if a patient comes into the emergency room and had chest pain that began only 20 or 30 minutes ago, you might not see ST elevations yet, but you can see these hyperacute T waves. And they can be hard to identify if you don't have an old EKG to compare to, but many patients have an old EKG on file, and if you look at that and you look at one in the setting of acute chest pain and you see these hyperacute tall peak T waves, that's evidence of transmural ischemia, very early evidence. And then another EKG finding that's associated with ischemia is called poor R wave progression. So if you look at this EKG tracing on the bottom of the screen here, the R wave is the upward deflection of the QRS complex, and then the final downward deflection is called the S wave. And this R wave normally gets taller in size. In other words, it progresses as you go from leads V1 to V6. And I'll show you an example of this in just a second. And normally the R wave becomes taller than the S wave is deep by lead V3. But when that doesn't happen, we call it poor R wave progression. And you can see this whenever there's ischemia involving the anterior wall of the left ventricle. This has to be transmural ischemia, but you can see it acutely when the patient first develops ischemia or even years later when they have scar tissue in the anterior wall from a prior infarction. So here's normal R wave progression. This is what the EKG should look like. So if we start in lead V1, we have a little tiny upward deflection, a very small R wave. The R wave gets bigger in V2, it's even bigger in V3, and now you can see that the R wave is taller than the S wave is deep. And then the R wave continues to get even bigger than the S wave as we go to V4, 5, and V6. Here's an EKG from a patient of mine who had a prior anterior wall infarction. In other words, a prior STEMI involving the left anterior descending artery that caused ischemia and scar formation in the anterior wall of the left ventricle. You can see that here we are in V3 and we still have a very tiny R wave. It's smaller than the S wave. And in fact, it's not until about lead V5 that the R wave is finally the same size as the S wave, or maybe a little bigger. Maybe by V6, the R wave is a little bit bigger than the S wave. So this is called poor R wave progression. It's an EKG finding associated with anterior ischemia. And that concludes our first module on coronary ischemia.